Every woman ages differently. Every woman goes through hormonal loss differently. That said, knowing when to start hormone replacement therapy is crucial because we want to benefit from them as best we can for long term health. And to do that, we have to try and start them at an optimal time. Unfortunately, mainstream medical advice is typically that you have to wait till you are in menopause before starting hormone replacement therapy. And that advice is really damaging to us women because it's the perimenopausal years where the symptoms start. So it's before we lose our cycle that we can really start to suffer with the symptoms of ovarian function loss. So when we start to lose those very vital hormones. And so it's really important that we understand when can we safely start hormone replacement therapy. Now, I like to think of this journey in four phases. Phase one being the age 35 to about 40, 42. Phase two is between the ages of 40 to 45, 47. And then phase three, 45 to around 52. And then phase four being 52 and beyond. Now, when I'm referring to the natural progression of hormonal loss, this is for women that do not have any outside influences coming in that will affect their hormones. Now, many women fall outside of this due to several different factors, including one being a hysterectomy. Now, if you've had a full hysterectomy where you've had your ovaries removed, that sends you into menopause immediately. If you've had the ovaries removed, or sorry, the uterus removed, but not the ovaries, then you won't go into menopause as quickly. However, without the uterus, your ovaries can atrophy faster. So, women that have had a hysterectomy where they've just removed the uterus and left the ovaries can still have a faster menopausal transition time. So if you're either one of those, you could be affected and you may not fall into one of these four phases as far as the age goes and when this is happening. The other thing is thyroid medication. Now, this happened to me where there's certain thyroid medication, specifically T3, more so than T4, that can raise a protein binding globulin in your body called sex hormone binding globulin. Now, this protein will bind to primarily testosterone and estradiol and make it so that you don't, if the higher it goes, the less free testosterone and free estradiol you'll have for your body to use. And so we don't want sex hormone binding globulin going super high because it binds up all your hormones, these at least testosterone and estradiol, and can even affect thyroid binding globulin in some cases as well. But if you're on thyroid medication, this can be happening. And birth control, oral birth control, can as well raise sex hormone binding globulin and thyroid binding globulin, which so it'll bind up your thyroid and bind up these very crucial hormones. So then you are left feeling the symptoms of hormonal loss, even when on blood work, your hormones may look like they're in good level, but you are getting the symptoms of the hormonal loss. And so you are going into perimenopause or menopause when you actually have lots of hormones, but they're not available for your body to use. Another one is diet. We do see that women that have had long-term or have been on long-term low-carb ketogenic diets, long-term carnivore diets, this can affect some women's fertility status. And so it can actually lower your fertility hormones. So you'll see it lowering estrogen, progesterone, and thyroid. This is because you're signaling to your body for too long that there's not a lot of food around, that you're in winter time, and it's not a good time to get pregnant. So your hormones can take a dive. And I've met many women, have worked with many women who this has happened to, where they did long-term ketogenic or low-carb diets, carnivore, or they're fasting a lot and doing a lot of intermittent fasting, or 4-day fast, 3-day fast, 24-hour fast, or they're eating one meal a day for extended lengths of time, and they lose their cycle, they lose their period, and start going into menopause early. So these are factors that can influence how fast you can go into menopause. Another one that we see, and we just saw it recently in our group with a woman, is women that were vaccinated for the COVID-19 vaccine, or they had COVID-19. And because of that, either one of those, they lost their period, even though they were young, fertile women, and their period stops. Now, this isn't conspiracy, it's out there. I mean, John Hopkins Medical Center was actually given $1 million to research why this was happening, because they saw it mostly with the vaccination, that women were getting vaccinated and it was affecting their periods. And I've met countless women who said they lost their period, or the other way around, where menopausal women were vaccinated and afterwards their period came back. So it definitely, it affected the ovaries. So we've had some women that have gone into an early menopause because of being vaccinated, or, like I said before, getting COVID-19. So those are kind of like the top things that we'll see. There's other things like high amounts of stress, trauma can cause premature ovarian failure. So there are other things that can contribute to this, but those are the ones that we see quite a bit in our practice. And so you don't fall into my 4 phases, because you could be 25 and have something like this happen to you because of one of those reasons that I said, or for a different reason altogether. Another thing that can influence our how we're feeling when we lose, and like the symptoms that we get, is our genetics. So genetics can influence how we feel when we start to lose those hormones. And so some women, for instance, they'll lose just a little bit of estrogen, looks great on paper in their labs, but they don't feel well and they're getting a lot of terrible symptoms from it. Rather, some other women, it's their testosterone. They may lose a little bit of testosterone and they get a lot of symptoms from it. And so genetics can play a part in it. Also, just sensitivity in general to hormonal loss. Some of us are just hormonal, very hormonal. I would say I'm one of those. I'm going to raise my hand. I've personally been on progesterone, for instance, since my 20s, because I had endometriosis. And so I was put on, my doctor was very forward thinking, and she knew a lot about bioidentical progesterones. And she put me on natural bioidentical progesterone therapy. And I was on and off it through my 20s, and it now since my 40s. So for some women that are sensitive, they may need it sooner than others, and they don't fall into these categories. So you can see now that it isn't a straight answer to when is the absolute best age, per se, to begin HRT. What we need to do is tune into our body. And if you are experiencing a lot of hormone dysregulation in your fertile years, you could consider using different forms of HRT, or using supplementation and doing lifestyle things. So there are many different things that you can do before reaching for that HRT when you're in your younger fertile years. But it's safe to say that for most women from the age of 40 and up, they can safely use and begin HRT. Now, that's not for everybody. Let's be really clear. This is not medical advice. I am just telling you what we generally see with clinical experience, what the research shows us. But I'm going to just say it again, every single person's different. And so you really have to listen to your body. I get messages all day long of women going, should I start my estrogen now? Should I start progesterone now? So I'm going to help you to help yourself in today's podcast so that you can figure it out if it is your time or not. So, typical journey looks like this. 35 to 40 phase 1, we begin to lose progesterone. And this is because we stop ovulating as often. And when we don't ovulate, we won't produce the bulk of our progesterone. We can produce some in the spinal cord and the brain and out of the adrenal system. So there's different ways that we can get a little bit of progesterone, but the bulk of the progesterone is produced from ovulation. And so as we age, we stop ovulating as often, and then altogether we completely stop. And then our progesterone is next to none on lab work at that point. These 30 from 35 to 40, this is when we typically start seeing progesterone just starting to go down a little bit. Now, symptoms you're looking out for: heavy periods, maybe a little bit of weight gain, sluggish thyroid. Now, this is something that we see more and more of in our practice where it's just like women in their late 30s, early 40s, never had a thyroid problem before. Suddenly they're on the low end, and it's typically not out of range. The range is ridiculously wide for thyroid. So it's, low end of range, almost out of range. And so doctors will ignore it and they'll just say, oh, yep, you're good, even though you're point 0.1 away from being flagged. But this is really common. And I think thyroid needs to start coming into this conversation more. Like we talk so much about estrogen, progesterone, testosterone. But thyroid, we see going down as well in many, many women in perimenopause and menopause. So that's one of the markers that you always want to be looking at, even if you've never had a problem with it before. And it's not looking at TSH, thyroid stimulating hormone. That's what most doctors will test for, and they'll leave out free T3 and free T4, which is the two major ones that we want to be looking at. And so make sure you're testing free T3, free T4. So as our progesterone drops, thyroid can be affected by that progesterone loss because it helps thyroid to function better, can help with that conversion. So always be looking at that. Insomnia. We know that progesterone loss can cause insomnia. It can cause anxiety, sore breasts, heavy bleeding is a really big one, because now we have estrogen usually in really great levels in phase 1. But because that progesterone starts to go down, and sometimes not every cycle we're producing it, now we can have unopposed estrogen. So the estrogen is not necessarily too much, but in comparison to your progesterone, it is. And then you can get symptoms of estrogen dominance. And that can include the heavy bleeding, period cramps, fibrocystic breasts, sore, tender breasts. Uh, and that is all from the loss of that very crucial progesterone. Now, when you're in phase 1, usually you can take herbal supplements or different supplements that will help your own body's production of progesterone. And this will only work for a short period of time because once you stop ovulating, there's no amount of herbals or vitamins and minerals that is going to bring back ovarian function. One of my favorites for that is Vitex. Vitex is really great to use in younger women to help with progesterone levels. Vitamin C can help. Ashwagandha can help. Anything that supports the adrenal system can help. Regulating your stress, watching your diet, all those things all have to be part of it. And that can all really help. And a lot of the time, women can regulate their cycle or help mitigate the symptoms of that progesterone loss by just simply taking these supplements. But at the same time, you don't have to be afraid of going straight to the punch. As in, if you want to try progesterone at that time in phase 1, you certainly can. And it's not going to be dangerous to your body. The beauty of hormone replacement therapy is if you don't need it, you'll typically know pretty quick. If let's say you've ovulated, but you're wanting to try progesterone cream and you start using it, You can get symptoms of excess, which is bloating, water retentive, sore, tender breasts, weepy, depression, fatigue. And you can stop that progesterone. And within like literally 2 days, those symptoms will disappear. And that's the beauty of this is it's not going to cause permanent damage or hurt your system. It can be mitigated so fast by just simply stopping using it, and it's over. And we've had many women that have tried this. I've had many friends that have tried because they'll hear me talk about progesterone or estrogen or whatever, testosterone, and they're like, I want to try it. Oh my gosh. And so they'll go on it and they'll be like, I don't feel good. And I'm like, just stop it. You'll feel fine. You just don't need it right now. So you can try it and it's not going to hurt. It's not going to damage. It's not going to stop you from ovulating. Now, there is something called a negative feedback loop where certain hormones are a little bit stronger with the negative feedback loop than others, which when you're taking in a hormone, it can cause your own levels to stop being produced. But with progesterone, it's very mild. And I remember listening to a gynecologist talk about it once, and he was saying that progesterone doesn't have a negative feedback loop, which I think it does because there is a natural negative feedback loop that happens with some of our brain chemicals like luteinizing hormone and follicular stimulating hormone. So progesterone will help to lower luteinizing hormone when comes up. And that is what a negative feedback loop is. So it helps your body to regulate your levels depending on how much there is on the inside. Now, if you're a cycling woman, it's really important that if you're in this phase one, even anytime, if you're in any of the phases, except for obviously phase 4, you're still cycling. Even if you're still cycling just every couple of months, every 3 months, every 6 months, you have to cycle that progesterone because if you don't, you can affect your estrogen. And we don't want that because then if you downregulate your estrogen production, you'll go into menopause faster. And that's what can happen is if you put progesterone in every single day, which a lot of practitioners will say to do this, uh, and that's not natural. We produce progesterone when we ovulate, which is usually around day 14 of our cycle. And so we have high levels of progesterone in the second half of our cycle and almost none in the first half of our cycle. So if you start taking it every day, you're messing with Mother Nature, and you don't want to mess with Mother Nature uh, because basically you can start to suppress the estradiol production. And then without estradiol, you're not going to upregulate progesterone receptors, which means you won't get that progesterone as much as you should because you've downregulated some of the progesterone receptors. So that probably sounds confusing to many of you, but just keep in mind, you must cycle your progesterone when you're cycling. I think we should always cycle it. And I always recommend all my women that I work with to cycle their progesterone because Mother Nature does everything for purpose. And that one is really important. And sometimes we can't get estrogen high enough. And we're with the progesterone, it just seems when you cycle it, it just seems to work better long term. And so I think we should be always cycling it, but some women really love their progesterone, can't live without it, need to take it every day. And if that's the case, I'm not going to deny them of that because there're millions of women that do static dosing that are on progesterone daily in menopause and they're doing okay. But I just think if we want to get the most out of our HRT that we cycle our progesterone. Now, labs to look for, of course, low levels of progesterone, but the lab range is ridiculous for all the hormones. And they give you luteal phase, mid-cycle, or ovulation, and then luteal phase. So follicular phase, uh, ovulation, and luteal. So you want to test on day 21 of your cycle if you're still cycling. And if you're not cycling, still keep track like you're cycling. So I get a period right now every 3 to 4 months. I still have it in my calendar like I'm cycling. So even if I don't get a period, I just put in there that I did when I was supposed to, so that I know when day 14 is and I can start my progesterone. I take it for 2 weeks, I stop, even if I don't get a period, and then 2 weeks in, I'll start it again. So that's and then when I test, I still test on what would be day 21 of a supposed cycle. Uh, and I want you to do the same. So day 21 is the best day to test. And so then you're going to look at the luteal range for progesterone. And if you are below 10 nanograms per milliliter, then you didn't ovulate. You just didn't. And that's very low levels of progesterone. If it's on the end of that, so just above that 10, that's still not typically high enough to oppose the estrogen. And especially if you're having symptoms on top of that of low progesterone, then it's usually safe to say that you need a little top up of your progesterone. And sometimes some women, it'll be, 1 month they ovulate and they may use their progesterone cream or pills and be like, oh, I'm getting symptoms of excess. I'm getting really depressed and tired. What's going on, And so it means that they ovulated that month. They're producing enough progesterone. They didn't need extra. Rather, some women, they can even top up their own production of progesterone because they ovulated, and it makes them feel better to have extra in their body. So, once again, everyone's different. Listen to your body. Some women will tell them, pay attention if you're having like a really bad PMS month, and you can be like, you could probably go, I don't think I ovulated, and start using that progesterone cream. And if it's too much, then you're going to know and you can stop using it. Uh, but if you feel good and you're not having a lot of PMS symptoms, you feel like you ovulated, then maybe you don't use it that month. And so you can kind of go on and off as needed in that phase one. Uh, and then, like I said, it's not going to stop you from ovulating, which is great. It can be very safely used. You're not going to wreck your own production of it or do anything, that's harmful to the system. You just want to make sure you catch it. Like a lot of women, they don't realize that progesterone can make them feel that way. I would say most women don't. And so they'll have a practitioner that's like, oh, go on progesterone cream. It's the best. And go really high doses and take it every day. I've heard it all. And women are like, I'm so depressed. I don't know what's wrong with me. I'm just so hormonal. And I'm like, maybe it's the progesterone. Like maybe you don't need to be on it. So really tune into your system on that one. Um, but it's not going if like I said, the negative feedback loop, you can watch certain like FSH, follicular stimulating hormone, luteinizing hormone, hormones that are coming from the brain that are telling your ovaries basically ovulate, produce estrogen, produce progesterone. And so, if luteinizing hormone stays elevated, if your FSH stays elevated, you know then that you are likely in need of some hormone replacement therapy. And those are really two great markers to always test with your hormones. Same with sex hormone binding globulin, because if that's raised, then you could, even though your hormones look normal in normal levels, you could then equate, okay, I have normal levels, but here my SHBG is really high. So I'm not getting those hormones, which would explain why I'm having all of these symptoms. And then you could work on lowering SHBG and doing other things. But the FSH and LH just are really great. They can be a great confirmation that, okay, I am starting to lose my hormones. My body's struggling to make these vital hormones from the ovaries. And maybe it's time that I start some hormone replacement therapy. So FSH, LH, really good to watch. Now, let me see here. Okay, so the negative feedback loop, you can, like I said before, progesterone's not a super strong one, but there are ones that are stronger. So one of them is thyroid. So if you start taking thyroid medication, it has a very strong negative feedback loop and is going to suppress your own production of thyroid hormones. And this could be a whole podcast in and of itself, but this is why a lot of thyroid patients are underdosed on their thyroid medication because their doctor's like, okay, yeah, you got a little bit of a sluggish thyroid. We're going to give you some thyroid hormones. And they feel better for a little while, a couple of weeks, a month. And then they're like, oh, now I feel like crap again. And this is because your body reads that there's thyroid hormone and it'll actually downregulate your own production. And so then some women will go under even lower than they were before they started the medication. And so it's really important to optimize a person that's got hypothyroidism on thyroid medication and give them a physiological replacement dose so that they're optimized on that thyroid because that negative feedback loop is so strong. So you have to basically give your body what it needs from the medication because your own production is going to get suppressed. Testosterone is another one. So testosterone's got a really strong negative feedback loop. So if you start taking it, your own production is going to slow down. Now, it is one that if you stop your testosterone replacement therapy or your thyroid medication, in about a month's time, roughly, your own production will come back online. It'll come back to about where it was before you started your medications. So if you stop your testosterone, you'll have low levels for about 4 weeks, and then your own production is going to start up again, and it'll go back to usually where it was before you started the testosterone. Same with your thyroid. Now, progesterone, estrogen, a little bit different because you're still continuing to age. So if you're taking progesterone, for instance, in your late 30s, and then in your 40s, you decide to stop, you likely at that point aren't going to be ovulating anymore. So you're going to have even lower levels than when you started your progesterone. So I hope that makes sense. But yeah, estrogen has a little bit of a negative feedback loop. Um, it's funny because estrogen is one of the ones where I see sometimes where women can put estrogen replacement therapy in, and it helps with the ups and down swings of estrogen replacement, of your own estrogen levels. So estrogen can go a bit of a wild kind of roller coaster ride when we're in usually about phase 3, and you'll see estrogen go up high and then it'll go down low. And putting in a nice low dose of estradiol in a low amount can really help to stabilize that roller coaster ride. And so you won't get these great big swings. But I do have to say, I have seen a very small percentage of women where it doesn't help with stability. And the one month they're in a deficit of estradiol, they're having all the symptoms. We put them on estrogen replacement therapy, even their FSH is high, everything. So it's like, yep, you need estrogen. And then 3 months in, they're getting signs of estrogen dominance. And they're like, what's going on? And we check their levels and their levels are sky high. And it's like, oh my gosh, get off your estrogen. Now that's, like I said, very small percentage, very small percentage. In most cases, a low dose of estradiol will help create stability in that hormonal roller coaster. Okay, so some benefits of starting the progesterone early, because a lot of women kind of get it in their head like, I'm going to tough this out as long as I possibly can. Because, we're kind of martyrs, us women. Like, let's suffer for a while and see how tough we can be. And that's really not the way to approach it, because for long-term health, it's a detriment if you don't start it early when you need it. One study that I found, it said that women, let me just read it off the paper here. It was a clinical study showed that the higher the progesterone in the luteal phase, that's the second half of our cycle, and we're supposed to produce progesterone, 5 years prior to breast cancer diagnosis, the lower the risk of developing breast cancer. So progesterone counteracts the growth promoting actions of estrogen by downregulating estrogen receptors. It's like it puts the brakes on the growth. So basically, they're saying the higher the levels of progesterone, 5 years into, like, before being diagnosed with breast cancer, had less breast cancer development. And so that's really shows how breast protective progesterone can be. So we want to start it early. The other things that it can really help to avoid is one, a hysterectomy. Hysterectomies are the second most performed surgery on women, to number one being cesarean section. So hysterectomies are being like given out left, right, and center, like no big deal. Let's just rip out the uterus. And that's serious surgery. We want our uterus. It is an organ. It's not just about carrying a baby. Keeps everything in place in there. And there is like a gut uterus connection, like there is a gut brain connection, and that studies show that women that with hysterectomies can develop dementia faster. I think this is just because they lose their hormones so quickly when they've had a hysterectomy, especially a full hysterectomy. One of the main reasons women get hysterectomies in that phase 1, phase 2 stage usually is because they've got this unopposed estrogen, so it's making them bleed super heavy, really bad cramping. They get wretched cycles, and the doctor's like, "Let's just get rid of the uterus." And so women are like, "Yeah, get rid of it. I can't do this anymore." So getting on the progesterone, and really watching your levels when you're in phase 1 is really important. And so if you've got the symptoms, you've got, the labs to show as well, then get on it if your body needs it, because you could avoid having a hysterectomy down the road, because the heavy bleeding is going to get worse and worse without that progesterone on board, or it could be. The other thing would be an ablation. That's a very common procedure as well, where they cauterize the inside of the uterus because of all the heavy bleeding. So it stops that growth in the uterine lining. I definitely would rather a woman get an ablation compared to a hysterectomy. But once again, using progesterone can really help mitigate that. And anemia, iron anemia. So because women will start bleeding so heavy because they don't have any progesterone, they can get anemic. And that can cause a lot of really like serious discomfort and fatigue and exercise intolerance, thyroid problems. And also the low progesterone will start to affect your thyroid, like I discussed. Bone loss. So we can start losing bone because of the loss of progesterone. And that's not something that you're going to feel. Like, keep that in mind, is bone loss starts way before we completely lose the estrogen, progesterone, and testosterone. And all three are really important for bone production and turnover and strong bones. And so you want to stay on top of that, because that's something that sometimes can't be reversed later on. I know women that have osteoporosis, and they've tried to start their HRT, after being diagnosed with it, in hopes to save their bones. And it helped, but certainly didn't reverse it completely. Some women it can, but for some it can't. So you really want to be on top of that progesterone loss so you can avoid bone loss. Cognition, we want it for cognition, and we want it to avoid weight gain in midlife, because progesterone helps our metabolism to go up. And so you can help your body and its metabolism. And so you won't necessarily gain as much weight or any weight if you're on top of that progesterone going down, and you start topping it up in due time. Okay. Now, phase 2, as I said, 40 to like 45, 46, 7. Um, Typically during our early 40s, you can start progesterone. Some can do with a smaller dose, like 20, 25 milligrams, just kind of topping up their own, because their levels are like me, subpar, and they need that little bit of top up. Other women, it's like really takes a dive. Like mine took a hard dive in my 30s. Like it was done. Gonzo by the time I hit 40, I needed progesterone every single month. And so 50 milligrams is my typical recommendation there, for women that have really lost their ovarian function and the progesterone's low. But and there's some women that go all the way up to 75 milligrams, 100 milligrams of topical progesterone. When we're talking oral progesterone, you need to go higher dose because you don't get as much of actual progesterone. So you have to do it usually 100 milligrams to start. And then as you completely lose ovarian function, a lot of women have to go up to 150 to 200 or do like a combination of cream and oral. So, but you can figure this out on your own, ladies. Be your own advocate, be your own teacher, and like listen to your body. And it's like, okay, put a little more in. Does that make me feel better? Does that make me feel worse? And adjust it from there. Yeah, nobody knows better but you. So listen to yourself. Listen to what your body's telling you. Uh, Now in phase two, we can start seeing other hormones go. Now, it's not to say that, in phase one that estrogen can't start going down or testosterone. We just don't typically see it going down. Either of those going down in our 30s, more so testosterone than estrogen. But testosterone is a funny one where we produce less than half our testosterone in our ovaries. So some women, they lose it from losing ovarian function. Well, rather some don't. Some have really healthy levels of testosterone all the way through to their menopausal years. But phase two, we will see a lot of women start to have lowered levels of testosterone. That can cause fatigue, muscle loss, lowered sex drive, things like that. DHEA is one of our most abundant hormones alongside testosterone in our fertile years, and it is an age-related hormone, so it does go down with age. Really important to support your adrenal system, your stress, can help with insulin resistance, can help with building muscle. It's a precursor to making testosterone as well as estradiol. So that one I really want you to watch as you're hitting your 40s, and test it regularly. Same with thyroid. Thyroid after the age of 40 really goes down. So phase two, not only are we really going to be losing the progesterone at this time, but testosterone, DHEA, and thyroid can also start to go down. And in about 5% of women, I would say estradiol in phase two will also start to be quite low, but that's 5% or less, I would say, start to lose their estrogen in their early 40s. Phase three, now that's when things start going haywire. It gets a little wild in phase three. I need to come up with names for each phase, and phase three being the wild child. But this is when we start seeing that fluctuation of estrogen, where one month it'll go high, the next month it'll go low. Um, We've seen so many women who are just at their wits end because one month they're having low estrogen levels or symptoms of low estrogen where they're getting the hot flashes and night sweats and and they feel like garbage. And then the next month they're bleeding out and they're like, oh my gosh, now I've got an excess of estrogen. So as I said before, putting in just a really low dose, static dose of estradiol can usually help mitigate those really wild swings that happen in phase three. So this is the one that's most controversial. And I've had doctors reach out to me and be like, I don't know, we shouldn't be giving estradiol when they're in perimenopause. And it's like, but why? Like every other one of these hormones, if they're hormone practitioners, if they start going down, they're willing to top them up. Or if a man starts losing his testosterone, God forbid, it's like, oh my God, we throw boatloads at them, no problem. It's like, here you go. There's lots of testosterone to be had, lots of testosterone clinics, and they're getting all the treatment they need. But then women, our most important hormone that makes us feel so amazing, estradiol, and can cause so many symptoms of discomfort. Suddenly it's like, oh no, you can't have it until you have none. And then when you're just this complete hot mess, hot flashing all day, 50 pounds overweight, fragile bones, no brain left, you've quit your job because you can't think straight. Okay, now we'll give you estrogen. Like that makes freaking no sense whatsoever. It's just like it's the whole fear around estrogen that's driving that. And we have got to get rid of that narrative. Like it is harming us so badly because if we can catch the downhill loss, the loss of this very vital estradiol, and we can stay on top of it by replacing it, oh my gosh, you'll avoid so many horrible things that could happen in perimenopause, including the weight gain. The loss of estradiol causes more weight gain than any other loss of these on all of these hormones, like even thyroid. Honestly, I see more women gain weight from the loss of estradiol than a sluggish thyroid will. And it's all in the midsection. So that's when you see women just getting these great big bellies on them and they're going, "What happened? I've never had a weight problem." That is almost 100% of the time the loss of estradiol. So stay on top of this, ladies. Don't let some jackass doctor say to you, "You can't have estrogen until you are in menopause." It just is so. There's hormone clinics that like there's one, I'm going to just call them out because I think they need to change this, which is Alloy. Alloy.com, very popular online perimenopausal, menopausal support. You don't meet with any doctor, you don't meet with anybody. They just, you take a quiz and then they'll prescribe you hormones. Sounds wonderful, doesn't it? Uh, well, if you put on their quiz that you've had any cycle, even one cycle, in the last year, guess what? Guess what they're going to tell you that they'll prescribe you? Birth control pills. No estrogen. And sometimes I even had a client that was denied bioidentical progesterone and was offered a birth control pill instead. How much sense does that make when we know that birth control pills increase a woman's risk of breast cancer? So, and that estrogen decreases her risk of breast cancer. So, hello, how is that benefiting a woman's health in midlife? It isn't. It's harming them. And so watch your levels, but pay attention to symptoms because like I said before, some women, they lose just a little bit of estrogen and they're going to have all these symptoms. Other women, they won't get any symptoms. And so they're like, "Oh, I don't need estrogen. I don't need hormone replacement therapy." But what's going on the inside? Are you losing bone? How's your heart? Are you getting type 2 diabetes or insulin resistance? There's all of these little silent killers that start to creep up as you lose estradiol. And it's all so much of it is driven by just the loss of that estradiol. Estradiol has it influences over 400 different functions in your body. So that's a lot. I've actually heard 800. So we'll say between 400 and 800 different functions in the body that estrogen has an impact on. So it's going to influence or have, it's going to have partake in 400 to 800 different functions in the body. That's a lot. So, I'm talking about the main things here, your brain, your heart, your bones, all very important. But think, what about all the 397 other things, that or whatever that it could be affecting? That's a lot. We know that we have estrogen receptors in the eyes, in the ears, in our hunger centers, in our brain, in our skin. How much does it affect the aging of skin? Huge, absolutely huge. Collagen, joints, liver. Yes, liver, like everything. It affects everything. So as that estrogen drops, if you're not getting outwardly symptoms, that is not a reason to not start hormone replacement therapy. So be watching your levels then on labs, pay attention to your symptoms. Labs, FSH, you want to look at on day 3. If it's above 10, that's a sign that you could start using some estrogen replacement therapy. And then also look at day 21 estradiol levels. I don't like to give a number because, as I said before, everybody's different for how they feel with estrogen levels. But it's safe to say if whenever you test your estradiol levels, if you're coming in under 50, that's a really big, like, oh, you're probably very close to menopause. Although I have seen women less than 50 still having a period. So less than 50 picograms per milliliter, definite sign you need some, because ideally for your health, we want to see women on hormone replacement therapy, on estradiol replacement therapy. We want to see their levels above 65 picograms per milliliter. And that's like the bottom of the barrel. We want to see that they have good, healthy, like anywhere between 100, 150 can be a great level where you're going to get that brain, bone, heart protection that we need as we age. And so you can look at levels day 21, if it's, between 50 and 100, you're going to want to consider HRT, estradiol HRT. And that FSH, once it gets above 10, definitely once it gets above 20, because when we're fertile, it's usually below 5 FSH. And so the higher it gets, the more your body's struggling to make estradiol, and for your more it's struggling to ovulate. So watch, and look at those numbers, and then you can decide whether or not that's something that you think that you should personally do or not. Um, Remember the silent killers, though: immune system, osteoporosis, heart, diabetes, all of these things can really start to be affected by the loss of estradiol. So we want to stay on top of it. Um, if you're, and then there's even research, by the way, that shows when an FSH gets above 23, I do believe it was 23 or 24, um, shows a correlation with weight gain. So it's just kind of saying, like, okay, when estradiol drops to around whatever, and it makes a woman's FSH go to 23 and above, they see that that's kind of we're seeing an uptick in weight gain in perimenopausal women and menopausal women when the FSH starts to go up like that, starts to go above 23. So be watching. And women tend to feel good and feel their best when the FSH is suppressed. So the lower it is on HRT, typically the better they'll feel, and they'll be getting the benefits from it. So keep all of that in mind too. Now, phase 4, basically, that's when you don't have a period. Now, what's interesting is you can stay in phase 3 indefinitely when you use enough estradiol, HRT, and progesterone, because you can continue to cycle, like, and not, you're not going to continue to be fertile, but you can continue to have a bit of a period where you have a little bit of a shed once a month. It's not typically like anything like your period was. It's very light. You don't get all the PMS stuff with it, because your hormones aren't going up and down anymore. And you're on this dose, you're cycling your HRT. So you can continue in that phase 3 per se, like, kind of, because you can keep your levels to a level where you're still going to have a cycle, which is basically where I'm at. But I'm not on quite enough, because I'm still missing periods. Sometimes I usually go about 3 months and then I have a period. So, but like last month, for instance, I hadn't had a period for 2 months. So I increased my estrogen. I cycled it. I had a day 12 spike. I gave myself a day 12 spike. And then I cycled my progesterone, gave myself a day 21 spike of progesterone, stopped the progesterone after 2 weeks. And of course, I get a period. And so I think that was just a sign for me personally, that I wasn't on quite enough estrogen to build up a little bit of a uterine lining and shed it. So I personally want to continue with that, and continue having a monthly bleed just a little bit, because I know then that my estrogen's probably at a good level. I'm going to go get it tested this month just to double check, Practice what I preach. So if that's not you, fine. If you are in phase 4, you're menopausal, you're no longer bleeding, that's usually a pretty darn good sign then that your body is very low in estradiol and progesterone, and for some women, testosterone, for some women, thyroid, for some women, DHEA, pregnenolone, oxytocin. There's so many different hormones that you could look at, but the main 3 being estrogen, progesterone, testosterone. We do in menopausal years really see these take a dive. Like I said, testosterone can stay up for some women, but that estradiol and progesterone almost become non-detectable the farther into menopause you are, and that FSH and LH get really high. So at that point, you can be like, okay, I think it's safe to go ahead and start my hormone replacement therapy. I think I need it. But always good to still look at your labs. I still like getting a baseline. A lot of people will say, oh, we don't need to test you. I like getting a baseline. You never know. And then you can also just go, okay, this is our starting point. And then you retest in 3 months and make sure that the levels are coming up appropriately with that HRT. And then that way we know that you're absorbing it, that, okay, we're seeing an uptick in these numbers. That's great. Now we can keep going until we get to that nice level that we want you to be at, and where you no longer have symptoms, outward symptoms, but also that the inside is doing well. And we know that it's getting protected by these hormones. Now, if you are past the 10-year postmenopausal window, so there's a lot of research done on this 10-year postmenopause window where they say that's the best time to start hormone replacement therapy. Now, they have said women who do start hormone replacement therapy in that 10-year window can stay on it indefinitely for as long as they want, and it's safe to do so. So that's great. The Menopause Society now says that. I've always known that, but it's great that they say it because a lot of people go by their word. But that 10-year postmenopause window was really based upon taking oral estrogen, so old Premarin or oral estrogens. And after 10 years, they saw that there was an increased risk of heart attack and stroke because you're swallowing the estrogen. And when you swallow estrogen, it does increase your risk of heart attack and stroke. And so if you use transdermal estrogen, it doesn't increase your risk of heart attack and stroke. And so I never recommend women taking oral estrogen for this reason. So always take it through the skin, through the vagina. That's great. Injection, great, but never orally. Orally is causing a whole bunch of problems. It's going to raise that SHBG, it's going to raise thyroid binding globulin, causes more inflammation, converts into estrone, which is the fat producing estrogen, and inflammatory estrogen, and proliferative estrogen. And then one that's connected most to breast cancer. So we don't want that. So no oral estrogen. And so women can start hormone replacement therapy at any age. You can be, I've had women that are in their 70s that start HRT because they want the benefits from it. They want to feel good. They want to have a healthy, lubricated vagina. They want to have healthy bones. They want to have, some women are still getting hot flashes even in their 70s. So they want the benefits. They want to reap the benefits now too. So there is ways to do it. And, it's always good to have your heart checked and get a calcium score done, and, get everything checked, get all your blood work done and do it right. Work with a practitioner who understands how to do it. Always remember, you guys, we can help anybody. We've got resources for every person that wants help. It doesn't matter what your price point is. We've got something for you. We've got our over-the-counter hormone creams now where you don't need a prescription. So if you want to DIY it, go for it. Although it's not medical advice, but that they're there to support you in this journey. We've got our membership groups, which are very affordable for everyone, and you get so much help in there. We've got practitioners we can prescribe in every state, as I said. So there's help to be had. And so if you are in your older years and you want to start HRT, please connect with us or find a practitioner in your area that is open to doing that and understands how to do it properly, is a way to do it so that you can benefit from it and you won't get a lot of, weird side effects. So just, be careful and always good to try and work with a practitioner or so, really, really educate yourself on all of this because they're finicky. As you've heard here today, it's like it's not a cookie cutter, one size fits all approach. And so I can't say like, this is what you do, this is how you start it, this is how you're going to take it in this dosage with this delivery form. It just doesn't work like that. Hormones and each of us, it's so different. And so you have to be willing to experiment with your body and be like, okay, let's see what's going to work best for me. Work with an educated person or educate yourself on it and be as safe as possible. Get your levels tested if you can, all of those good things. Um, so if you want our help, KarenMartell.com. Our hormone creams are at KarenMartell.com/shop. And we've got progesterone, estradiol, and bias, which I will give you a testimony. It's somebody very famous. Just wrote to me to say, "Oh my God," she said, "Miracle Cream, OMG, I love it." And so she was telling me that she was telling another friend of hers in this industry who's also very well known that she had to get some of the bias face cream. So I have now several very kind of famous people using my bias cream for their face, and it's doing wonders for them. So there we go. Toot my own horn there for a minute. Anyways, ladies, that's where you can find it. So I want you to make sure that you're taking care of yourself during this time. And I really hope that today's podcast helps you to figure out when is going to be your best time to start HRT.